Rick.
Yeah, I just did, and it came up here. It's on now.
Okay, I see.
Yeah, I saw your note. Yeah, thank you. So, 3:05. We can get going here. Let me see if I've got everybody written down that I can see, and then we'll do the old roll call. Eric, I didn't see Eric. And who else do we have? Okay. So here's who I see. I see Jake, Bill Franklin, Ken Anderson, Ron Shaheen, Paul Hobson, Eric Bookbinder. Who else is with us?
On the phone.
Sorry, Eric, I've got you. Who was the other person?
Paul Frieda on the phone.
Paul Frieda on the phone today. Okay, Paul Frieda on the phone. Number 4.
I'm Sylvester Mann.
And Sylvester Mann, how are you, Sylvester?
I'm doing fine.
Okay.
Best regards to everybody else.
Good. Okay. So let me see.
Rick, Jim Harrington on the phone.
And Jim Harrington on the phone. And Ken Anderson, I'm hoping that Steve Bornstein is going to join us. I sent him a note and he said he would try. So we may just have to give him that he comes in a little bit late. And but I really would like him to be on the line when we address your situation. So we may just divert just a little bit. So let me see. I'll read through my list again. I think I've got everybody now. Jake, Bill Franklin, Ken Anderson, Ron Shaheen, Paul Hobson, Eric Bookbinder, Paul Frieda, Sylvester Mann, Jim Harrington. Did I miss anybody?
Peter's on.
Peter. Sorry, Peter. I'm looking at you and I didn't write you down. Beg your pardon. Okay. So let me run through. We have one new gentleman, Ken Anderson, who we spoke with on Peter's call yesterday, and I have communicated with over the last 2 or 3 days. Ken certainly belongs with our call. I'm hoping that, as I just said to Ken, that Steve Bornstein will join us because there's some similarity in the diagnosis, and I was hoping that Steve would be able to give Ken some comfort. Let me just see who else wants to raise something today, and then we'll decide whether we want to kick off with Ken or we just want to give Steve a few minutes to join us and come back to him. So Jake, do you have anything you'd like to talk about today?
No, Rick. I'm just happy that my Xtandi seems to be working right now. 15.7 to 3.2.
Okay, well let's come back to that then. So you do. So we'll definitely come.
Well,
Come back.
That was it.
Well,
that was my comment.
That's okay, but I got to write it down, and so I'll come back to you, and you can just tell us a little bit, and I'll ask you a couple of questions, and maybe some other people want to ask you about how it's feeling. Bill Franklin, anything for you, sir? No, I think he might have stepped away. Bill, are you with us right now? Okay, he may have stepped away. Ken Anderson, hello, welcome.
Hello there, thank you very much.
It's a pleasure. We'll come right. We'll give you a bunch of time. As I said, we'll just decide when in a minute. Ron, how are you today?
Oh, I'm much better, thank you.
Good, good.
I can give you a little quick update when you get a chance.
Yeah, okay, so we'll come to you. Mr. Hobson, I know you've got something to tell us because Jim Marshall told me what you have to tell us. So I'll let you share it with our people in a few minutes, okay?
I don't think I had anything to tell you today, so...
Well, for one thing, you're not in the same place you were when we spoke last time.
Well, venue isn't really an issue.
Yes, it is. Sure it is, because I'm sure you're feeling a lot better there than you were before. So you can tell us how you've transitioned.
Okay.
Okay. And I also understand you've been checking out scooters, so we want to hear about that as well, man. Eric, anything for you?
There we go. Now you can hear me. A couple of little update items.
Okay, so we'll come to you. Paul Frieda, how about yourself? Anything for you, sir?
Nothing tonight.
Okay. Sylvester, anything for you?
Not tonight.
Okay. Jim Harrington, how about yourself?
Rick, nothing tonight. I'll just listen.
Okay. And Peter, how about you?
Yes, I have a short subject I want to discuss.
Okay, good. So, and Bill sent me a message that he could hear me, but I couldn't hear him, so, but doesn't have anything that he wants to raise in particular, so that's fine. So, I think what we'll do, I want to give Steve just a little more time. I'll give him another 10 minutes or so, and if he doesn't come on, then we'll talk to Ken ourselves. We got plenty of guys that can talk to him here. So let's just start with Jake. Jake, how long now have you been on the Xtandi?
Excuse me. It's been about a month and a half now. I started it. I had my blood test last about a week and a half ago, and I was just thrilled to death. It had been rising, had gone up to 15.7, and then within 30 days, by the time I had my blood test, it was down to 3.2. So I'm hopeful that it continues to go down, or at least, even if it holds steady, I'll be happy. So 45 days approximately.
45 days from 15.7 to 3.2.
Well, actually, it was 30 days from 15.7 to 3.2.
Oh, okay.
I've been on it for about 45 days or so.
Okay. And how are you feeling? How's the fatigue and any side effects?
Don't feel any more tired. I think I seem like I have more aches and pains that I've noticed. They kind of move around. Mm-hmm. They're not consistent and they're not serious, but I just feel things. This aches today and that aches tomorrow, and
right.
Right. I think I kind of feel like I do feel a little bit foggy at times. I feel like I have a head cold. I attribute that to mental fog.
Something went through my mind to ask you about the Xtandi. Jim Harrington. Fatigue. How are you doing with the fatigue? You say you're okay? Are you okay?
You asking me that, or are you asking?
Yeah,
Jim?
I'm asking you, Jake.
No, I don't think I'm any more tired. I do take it about 10 o'clock at night.
Okay.
And I'm sleeping pretty well. I'm sleeping through the night, and I haven't noticed any real fatigue.
That's good. Jim, you've been on Xtandi for quite a while, haven't you?
Yeah, well, I was on Xtandi and it worked for about 6 months or so. Then the Zytiga also worked about 6 months, and now none of them work. But yeah, with Xtandi, I got some fatigue and the joint pain. Yeah, but you know, I'm also on Lupron for life, so never sure exactly where to attribute this. But joint pain, knees, and so forth. Yeah, it's there, or as you say, it bounces around for some strange reason. One thing that helped me, I was taking prednisone with the Zytiga, and it actually helps with the joint pain, but that couples with the Zytiga, so I don't know if you can really be careful with prednisone, but that does help with the joint pain. Other than that, I actually think Zytiga was a little bit worse in terms of fatigue during the day and so forth, but surely you get some fatigue with Xtandi. I think that's kind of common. But it's not bad. I'm very happy to hear that it's working for you. As I say, it worked for a while for me. I didn't have it as high as 15, but it did go down to 0.8, so it stayed that way for a while. Then it started going up. But best of luck to you.
Well, thanks, Jim. Appreciate that.
So much of it is really about how much PSA you make, and you know, Jim Harrington, you don't make a lot of PSA.
No, I don't make. I'm one of these guys who makes a little because my PSA is 2.6. You'd think I'm just rolling in clover, but that's not, in fact, the case. But you're right, Rick, and that's not so good because it's harder to diagnose and know what to do.
Right.
Not much I can do about it. So.
Anyone else? Oh, well, Steve just joined us, and Steve, you're taking Xtandi as well right now, aren't you?
Yes.
Yeah. So we're just talking Jake, in 30 days, his PSA's dropped from 15.7 to 3.2, which is great. So clearly you're not ARV7 positive, Jake. That's the good news.
Right. I don't think I need the test either. At least not.
And so we were just talking about, you know, how different people are responding to Xtandi. I mean, how's the Xtandi work for you, Steve?
I've been on it, I think, 5 months now.
Mm-hmm.
It's kind of controversial when I started it because it wasn't clear whether I was really castrate resistant or not because I just had radiation. But I started it anyway, thinking it was better than the KZX, and it's being paid for by insurance, so I might as well go for it. And it's okay. I mean, I don't have, I can't say that I have any side effects that I noticed outside my normal aches and pains and so on. I certainly don't have some of the common side effects. So, yeah, it's expensive, but if I'm not paying for it, it's a good deal.
Well, yeah, I'm fortunate. I was very concerned, and I've talked about it before. I was very concerned about the cost, and I found out that my insurance covers everything, and then Xtandi company, I forget the name of the company, they pay everything else. So my copay is $20 a month, which thrills me to death. I couldn't ask for more.
It's a good deal, yeah. Are you having side effects from it or not yet?
I was just saying I have a little. I feel like I'm talking sometimes through a, you know, like I have a head cold, kind of just a little bit of a pressure in my head. I'm thinking that might be mental fog. Not bad, you know. And I have occasional aches and pains. They move around though. They're not, you know, it's not always in my left knee or my right toe or whatever. It's just they kind of jump around.
Yeah, I was concerned about the increased rate of seizures, which was reported as high as 6%, I think. But I actually didn't.
That's scary.
That's scary. But I looked at the data pretty carefully and talked to Andre Harstark and others, and it turns out that of the, you know, in the clinical trial there were 7 patients total that seized, I think 7 or 8 or something like that, and 3 or 4 of them had risk factors. So one of them was an alcoholic, one had a pre-existing seizure disorder, and I forget the other one. One guy had head trauma or something. So it seemed like that was over, you know, just built over, and so, because the last thing I want to do is have a seizure on this stuff. It's not, you know, but it seems like that most serious side effect is probably not as high an incidence as the clinical data reporting.
And percentage-wise, it was pretty low, I believe, if I remember correctly. I read the literature too, and I think it was less than 1%, wasn't it?
No, it was about 6%. It was close. Oh. But the data itself was somewhat faulty because, they included these people that had risks for seizures, and so, I don't know what that all means. Anyway, I just took that.
Yeah, I had thought it was lower than that, but I'm not. Obviously you've looked at it recently, so.
We can go look at the data and see. I thought it was, it was a while ago. It was 5-6 months ago. It might have been 4%. It was higher than 1%.
Yeah, it's pretty low.
It was
Anybody else? Anyone else on Xtandi that wants to chip in here? Have we gotten everybody that's using Xtandi right now?
Somebody needs to mute their phone because there's a lot of feedback or something.
Don't know.
I think it's Paul Frieda, actually. If everybody else be quiet for a second.
Oh, you're getting noise from me?
Yeah, I think it's you, Paul. I think that if you could mute when you're not talking, I keep seeing your name flashing up there when we hear that background noise.
That'd be great.
Okay, I'm going to try mute right now.
Okay.
Okay, that's just my theory. I can't guarantee it, but I just keep seeing your name flash up there and you're not talking.
It sounded like somebody talking from underwater or something is what it sounded like to me.
Yeah. That may be better. Is that better?
Yes, definitely. Thank you, Paul.
What do you know? See?
So what we're going to do, I've got for people who want to have a little time, I've got Ron, Paul Hobson, Eric, Peter, Steve. Did you have anything you wanted to bring up today, or?
I'm just cruising at this point. There's nothing new with me, so I'm just happy to listen.
Okay. Well, I mean, we're really glad you're here because we want to give Ken Anderson some time. Ken, why don't you give us a similar sort of update to what you mentioned yesterday on Peter's call. I mean, your age, your PSA history, your history with your prostatitis, and then what's happened in the last 2 to 4 weeks.
Okay, I'll do my best. So for me, what happened was, years ago in 1999, I started basically my 50-year physical kind of inspection by my doctors, and it was kind of advised to me to start it by an older guy that was a doctor at Ford Medical Clinic. He said absolutely. He took care of the Ford family. He said absolutely go in every year and have your PSA checked and be careful with your health. And for years I did. In 1999, I ended up getting prostatitis, and at that time my PSA, was in the 500 plus range, and I took antibiotics and knocked it down.
500? I'm sorry, did you say 500?
Correct.
Oh.
It was 572.
Mm-hmm.
I was in 99, and I, even then, I started gathering information on prostate cancer, because honestly I have a folder in my office and I collected stuff. Every time I went in, I collected stuff on prostate cancer. Why, I have no idea, but I did. The next year, I went in and it was within the right range. The antibiotics took away the prostatitis and everything was fine. A couple years went by and it was fine, and then another year comes by and I have a PSA of about, I'll have to try to remember this. It wasn't astronomical, but it was still in the hundreds. And I went back on this antibiotic and took it away. And again, it was found during my annual physical. The second time, the first time it was because I had pains. I had back pains and I knew something was going on, but I didn't know what it was. And so I went in, and it wasn't during a normal physical. I went into a doctor that I was going to, and he said, oh, it's prostatitis, take a bath and, relieve yourself from time to time, steam in to get the stuff cleared out of your system. I did what he said, and then the next year it was prostatitis again. I went on antibiotics and it went away. And then 3 years ago, I went in for an annual physical, and Dr. Block, this gentleman that told me to go every year, had passed away from old age, basically. And I go in and my PSA is at 14. So this doctor who's here in Phoenix referred me to a urologist. I'll try to leave the names out, I think, but he referred me to a urologist that's now retired. But at 14, which was 3 years ago, he did a digital rectal exam. We did the blood test. And he basically told me everything's fine, go away, you're healthy, you don't have anything to worry about. So honestly, I didn't worry about it because, again, my PSA in the past had been in the 100. So I figured 14 was really no big deal. It didn't raise a red flag. Dr. Block would have said, no, that's a big red flag, go back in a couple months and have it tested again. But I didn't go back and have it tested again. Not only that, my dad got sick and he was living with me, and he ended up passing away last year from nothing other than he drank too much and he smoked too much and he just didn't take care of himself. But during the last 3 years, or the last 2 years, I was pretty much focused on taking care of him and not myself. And I didn't have any health issues. I'd go in, take baby aspirins for my doctor for possible heart attacks or strokes, and going for my flu shots. But anyway, I'm kind of getting off track. Anyway, I was 14 and I didn't do anything. I didn't go back and have a check 6 months later or 3 months later to say what's going on. So I go in, and most recently, 30 days ago, January 15th, I go in and my PSA is 562 or 526. And immediately my doctor, who I've known for years, sent me to another urologist because this other doctor was retired, which is a good thing. So I go to the urologist, and he says, oh yeah, there's stuff going on. You have a 562 he wants to do. And he has a large practice here in Phoenix. He wanted to do a biopsy, and he did 18, he did whatever the biopsy is called. He pulled 18 samples, and lo and behold, the Gleason score comes back at a 9 because 99% or 95% of my left side's infected and 70% of my right side's infected. And at the same time, he orders, after he gets this, before he gets the kind of the information back, he says go in for a bone scan and a CT scan. I'd scheduled them both, but the bone scan was delayed because the place that I went didn't have the apparatus, so I go for the CT scan. That information comes back, and it's found that 6 of my lymph nodes are inflamed or enlarged. So there was evidence, without doing anything else, that it had migrated from my prostate into my lymph nodes. And at the same time, my bone scan was scheduled. So I went for the bone scan. I just got the results back on the bone scan because I'd met with the urologist yesterday and had an appointment today with I met with the oncologist, had an appointment today with the urologist. The oncologist had the results from the bone scan, and it's kind of all in mumbo jumbo to me, but it basically says, yeah, there's activity in your bones. Not in 1 or 2 places, but in 12 or 13 places. So right now, 2 weeks later, I know my Gleason score is a 9. I know it's migrated to my lymph nodes, and I know it's in my bone system. And the most recent PSA, which was done on the 15th of November, was 762. I started taking during the first visit, which was on the 15th or 16th of February, some pill called biclutamide or something like that, and then Monday I took the first shot of Lupron. And surprising to me, the oncologist said, there's nothing else we're going to do for 60 days. We can come in if you want in 15 and have your PSA tested to see if it's moved at all, but quite honestly, it's not going to move much for a couple of months. There's not anything else we can do for you. Basically, go away and have a beer. And that's kind of where I'm at. I have, in fact, reached out because I have another client. I'm a real estate broker in Phoenix. I've been for 30 years, 28 years. So I reached out to clients that have sorry.
Take your time.
Anyway, I reached out to clients and they said, you know, I have to breathe. They said to go to MD Anderson in Houston. So at the moment, you know, I have a request in MD Anderson, and they have been in communication with me today. I put in the request on Sunday via the internet because I have 3 clients that are fairly wealthy that said, you know, they fly themselves anywhere. They said if, and they, 2 of them have prostate cancer, advanced prostate cancer. They said they would go no place else other than going there and seeing this Dr. Logothetis.
Chris Logothetis.
So the one guy who's a, you know, he's a very nice guy. He called the secretary or the administrative assistants for Dr. Logothetis and asked, and he in fact asked for, you know, him to see me, but I have no idea of his schedule, and that's what the girl that I talked to today, she said it's either going to be him, and I have a tentative appointment scheduled with this other guy that you referred me to, and I think it was on the on here last night. It was some guy called Crown.
Corn.
He is scheduled, the earliest he could see me was the 23rd of next month. So, I mean, at the moment, that's where I'm at.
So, first of all, I do want to say that, you know, the thinking today is a little different to what your Arizona oncologist told you, that we can't do anything for 2 months. I mean, that is the old school. There is a new school. I'm going to ask Steve. Steve had, and by the way, I don't think you mentioned, but you're 56. Is that right?
That's correct.
Yeah. So Steve is a little older, but he had a similar situation where it sort of crept up on him and boom. And Steve, why don't you fill Ken in a little bit and talk about what you did when you first got diagnosed?
Well, I mean, Ken, I'm sorry to hear this story for sure, because, you know, it's especially the first few months after you hear this, it kind of throws a hand grenade in your life path here, and you just don't know what to do or what to think. I'm pretty close to about 1.5 years after a kind of a similar story, except in my case, because I'm stupid, I decided not to do any PSAs at all for about 10 years, with my doctor's advice and consent, I might say. But it was interesting that you had this premonition about prostate cancer, you know, with this 500 and a 700, whatever levels. I doubt that was prostatitis back then, but it's interesting. You kind of knew better than your doctors. And I can say this because I am a doctor. So anyway, the 60-day thing, let me just say, is based on the clinical trial with docetaxel for metastatic prostate cancer prior to it being castrate resistant. If you take 6 doses of docetaxel within 60 days, the overall survival is dramatically improved. So that's why they're saying 60 days. So I'm assuming they're going to see what the Lupron and the Casodex do for you, and then at 60 days start the first course of the docetaxel, which is a chemotherapeutic. I chose to start it right away, and it's really, the clinical trial is done within 60 days, however. So I don't think they're saying go away and we can't do anything for you. I think what they're saying is probably go away, come back in 60 days, we'll see what response you have, and then start on the chemo. So that's just my first thought. And then, I mean, you're about to start on a long, long path here, and, you know, there's lots of different options that we could probably all talk about. Most of us in this this session have been on most of them. So, you know, I don't know where you want to go from here, but I do think getting a second opinion at MD Anderson or somewhere else is always a good idea, for sure.
Steve, by the way, Steve's PSA was just over, fractionally over 1,000 when he was diagnosed. So, you know, there's some comparability. Before we start talking about treatment options and where to get treated, is there anyone else who'd like to talk to Ken right now, and you know, any thoughts of support, or how you each managed to handle your diagnosis if you were diagnosed at a late stage?
Ken? Ron Shaheen here. I've been fighting prostate cancer for 14 years now, and my PSA before I started chemo a little over a year ago was at 800. Over this period of time, my PSA has fluctuated back and forth, and I've done almost every treatment that has been FDA approved. Some were great. I think the Lupron and Casodex hormonal treatment is to kind of get in there and slow down the testosterone, cut back the testosterone, and see if they can cut back on some of that PSA growth, prostate cancer growth, and then move on, like Steve has said, to the next treatment level. The thing is that while you were, you know, went through some hiccups early on over the last multiple years, prostate cancer at this particular stage, even though with a Gleason 9, is something that you don't have to rush into. I mean, to be worried too much about. You have seen some doctors, and they are on some appropriate treatments. So I think you just need to keep a positive attitude. I think if you can get a second opinion by some more contemporary doctors, it will be helpful to you. So that's just my take on it.
Thanks, Ron. Anyone else like to chip in? Let's just maybe talk a little bit about the treatment, Ken. Well, let me just stop here and say, do you have any questions, specific questions that you'd like us to address, or somewhere you'd like us to go in responding to you?
You know, the biggest one that comes, and again, it has to do with my scouring the internet, and I'm going to have to stop doing that, I know, because it's all over the place as far as, you know, what you should be doing and how you should be doing it, how frequently you should be doing it. You know, stuff like cannabis and, you know, herbal therapies, and I mean, the biggest thing that seems to be what everyone's talking about is this metformin or whatever it is, and an aspirin each day.
Metformin.
But,
yeah.
Metformin, right?
Yeah, metformin.
But I don't know what it does. I don't know anything about it.
So let me try and help you. Just give you some perspective. There are complementary and there are alternative treatments. So complementary treatments are treatments that may not be necessarily common in Western medicine. They're not really frowned upon, and they supplement the Western medicine. So they're not going to hurt you. They may help you. Some doctors are open to them, some doctors are not. Most of the better centers of excellence now have specific integrative medicine centers where they will address issues like diet and exercise, stress relief. Some recommend certain supplements, some do not, but they're all in conjunction with the existing treatment that you get. Those are all called complementary. Then you have alternative medicine where people not people, I shouldn't say people, where the protocols are considered as an alternative to the treatment that you're taking. So there are some people out there who believe that certain types of cannabis may in fact cure cancer. There's absolutely no clinical evidence for that, although there is certainly a place for cannabis in cancer, usually as a palliative agent. It can help with pain, it can help with nausea, it can help with appetite, but it really does not seem to cure cancer, and it certainly doesn't cure an advanced cancer. In addition, there are drugs that may be effective in controlling prostate cancer, but they're not going to cure you. They may hold back the speed at which the cancer grows, and those are drugs like metformin, which is controversial, but probably doesn't hurt you at all, doesn't have any side effects. If it were me, I'd be taking it. I don't need it, but I'd be taking it. There are a bunch of guys on this call right now who are taking it. And maybe it's slowing down the growth. In addition, a statin is also recommended. I think the main reason for that is because the cancer gets really smart. It's able to break down cholesterol and extract testosterone out of the cholesterol, because testosterone is a core builder or maker of cholesterol. So the less cholesterol you have in your body, the better you are. So there are schools of thought that believe that you should take metformin, you should take cholesterol. None of these things are really going to intercede to stem the disease the way that you need it to be stemmed. And that sort of treatment is probably going to come initially from hormone therapy and chemotherapy. 3 years ago, 4 years ago, nobody really considered chemotherapy for early treatment of prostate cancer. It was really only used at late stage after the cancer had become resistant to the hormones. It had spread extensively to the bones. Now, today, we seem to think, I shouldn't say seem to think, we do think, and we have clinical evidence that interceding with chemotherapy early in the disease path is one of the most effective ways of increasing overall survival. So, as Steve said, it really is best if it starts within 60 days. I don't know if that's in the mind of your fellow at Arizona Oncology or not. Ideally, what would work best for you is if you could find a local physician, a local medical oncologist who was willing to work with one of the oncologists at a center of excellence like MD Anderson or UCSF. Because to have to schlep to Houston or San Francisco just for a chemo infusion is not going to be too convenient for you. So ideally, what you want to do is try and find somebody that where they can work together. You know,
is that done?
Say that again.
Is that something that is done from time to time?
Yes.
You know, the MD Anderson, they have a facility here in Phoenix, but I was told that I should not go there for kind of the proper protocols, that I should go to the one in Houston to get checked out, and then if in fact, so I guess what you're saying is that if in fact that this Jerry Lucas at Arizona Oncology isn't willing to work with whomever they stick me with at MD Anderson in Houston, that I should switch and go to MD Anderson in Mesa, which is, you know, it's a 40 or 35-minute ride from me, but it's the same as Jerry's office.
Right. I guess what I'm saying is that if you could have your treatment supervised by somebody like Chris Logothetis or Paul Korn, but you could actually get the treatments and the protocols locally in Mesa, then you're going to be doing fine. I mean, the fact of the matter is that you don't really need to physically see your medical oncologist all the time, as long as you can speak to him, as long as he can see all your results. I mean, yeah, you know, it's good maybe a couple of times a year that he physically examines you, but if he can supervise your results and indicate what he wants administered, and you can get it done locally, then that's a really good situation. And one of the issues with prostate cancer is that the treatment is it's quite specialized, and B, it's moving exceptionally quickly, and the general medical oncologists are not always up on the treatment of prostate cancer. So it's really important that you have what's called a genitourinary medical oncologist. That's a medical oncologist who specializes in the genitourinary cancers, which includes prostate cancer, as your quarterback.
So why haven't they recommended, you know, like gene sequencing yet?
Why haven't they recommended gene sequencing yet? Because what they first want to see is how you will respond to the Lupron and to the hormone therapy and to the chemotherapy. Because the purpose of doing the gene sequencing is to try and determine if there is a drug out there that you may respond to well, but it's not a first-line drug. And there are first-line drugs, there are second-line drugs. That's not to say that it couldn't be administered in a first-line situation, but our thinking just isn't that far along, to be quite honest. I mean, you know, right now, we're at a point, you'll hear when we talk to Ron Shaheen later on in this call. I mean, right now, we're at a point where we have to try and get people to get their gene sequencing either from their tumor or from their blood at some point in the disease. Whenever, you know, even later on in the disease, we're having trouble convincing the doctors. Now, if you went down to MD Anderson, it would be easier, and they may even want to sequence your gene earlier. The only thing is that MD Anderson isn't part of either the Dream Team East or the Dream Team West, if I'm not mistaken. I don't know why, but they're not. So the Dream Team East and the Dream Team West are two teams that have been set up with huge grants from Prostate Cancer Foundation, Stand Up to Cancer, and others, where they're doing a lot of research. They've been going on about 3 years, and they do a lot of research into gene sequencing. So if somebody like you comes along, they're likely to do a gene sequencing right away because they want to track how your genes are changing over time. The other thing that you should know is that that prostate cancer changes over time. So if we sequenced you today and you responded to the current medicine, but 2 years from now or 3 years from now you'd stop responding and we couldn't find anything, we probably would have to sequence you again because the disease would probably not be the same as what it is today. The other thing that is again controversial, but we're seeing it much more, and again I'll ask, since Steve really used this, I'll let him talk about it again, but in the past the convention was not to treat men diagnosed with metastasized cancer with any first-line interventional therapy like surgery or radiation. But what we're seeing more and more, and there are trials going on at Memorial Sloan Kettering in New York and in other places, is that there may be some reason and some sense to debulk the cancer, meaning to take out even though the cancer's out the prostate, that there could be benefits from debulking the cancer. Now, Steve, in a second, will explain that better to you, because as a surgeon, he used those processes himself in treating ovarian cancer, and I think that's one of the reasons he decided. But maybe there is some sense to some primary treatment that somebody like your Arizona oncologist wouldn't even consider. Steve, you want to talk about this whole idea of debulking?
Yeah, it's very controversial, and it's not past at the most a phase 2 trial. But I mean, the theory is if you get rid of enough of the cancer cells, your immune system is better able to cope with the remainder of them. So I'm a gynecologist by training, and so we always, no matter how far widespread the ovarian cancer was, we would always remove or debulk as much tumor as we could surgically. That's not to say, though, I'd have a radical prostatectomy in your situation or my situation, because it's a very morbid procedure for no known benefit. But the advances in radiation therapy, in particular stereotactic radiation, IMRT, the so-called CyberKnife or the variant machines, basically computerized radiation, high doses given in limited intervals, has proven to be very effective as primary treatment for prostate cancer inside the capsule. So I chose to do that. I had stereotactic radiation to my prostate, early on in the process. The other thing is there's some theoretical, there's something called an abscopal effect, which is your immune system is enhanced by releasing certain antigens as cancer cells die. Because the only thing that's going to give you real longevity here is if your immune system somehow figures out a way to fight this. All of these chemotherapeutics and radium and the hormones are really temporizing, and at your age, at 56, the likelihood of you dying of something else is not as high. I just turned 68, and I could die of something else before my cancer gets me, but at 56, the likelihood is you won't have a heart attack or a stroke or some other horrible thing that happens to you. So you have to try to think about the longevity piece of it. My only piece of advice, the other thing you have to realize is that most insurance won't cover this, all these so-called experimental or non-standard treatments. I'm in a little bit of a unique situation in that I was a doctor with Kaiser Permanente for many, many years and have been able to talk my doctors into doing some things that are probably pretty non-standard as long as I'm willing to take on the risk, whereas others may not, other insurance companies simply won't cover that. So if you told your doctor in Phoenix, I want to have stereotactic radiation, so-called SPRT, they'd say, well, that's fine, but your insurance is going to cover it, and it's going to cost you $80,000. So it's limiting in terms of what you can do because of the insurance standards in the United States. But I think the most important thing, as Rick is saying, is that you have somebody that's up to date with modern treatment. The clinical trials, was it the Stampede trial, Rick, or which was the docetaxel trial? I think it was Stampede, right?
Charted.
Charted, yeah, Charted. The clinical trials, I'm kind of getting confused with them. So the Charted trial, in someone in your situation, showed, a very significant improvement in overall survival that's given in that first 60 days. So that's a no-brainer. You should be starting on docetaxel chemotherapy as soon as they offer it. It's a bitch. I mean, those of us that have been through chemotherapy can tell you it's no fun. It's 6 courses given at 4-week intervals, and it's it's no fun for sure. But there's no question in some of your situation, it would improve the overall survival dramatically over just hormones alone. So that's the first sort of stumbling block you have to get across here, is that you really need to be not just on hormones, but you really should start on docetaxel chemotherapy pretty soon, within 60 days certainly.
So is that something that I should in fact discuss with my oncologist, or is that something that's done by, because it sounds like this particular oncologist, all he does is radiation treatments.
So
No, it's
docetaxel.
by an oncologist. I mean, the chemotherapy is always, it wouldn't be a urologist. A general medical oncologist may not be that familiar with all of the stuff, although this has become so standard in the last few years that I'd be surprised if a general medical oncologist doesn't know of it. But this is why you get a second opinion from somebody that sees prostate cancer a lot, if not only. And but I would look up the charted trial, read through that, and then I would go to whoever you're seeing and say, you know, seems like this is what I should be doing. And if they say no, I don't believe in that, I would certainly I'd certainly question that.
Well, that's why I'm going to. I mean, I'm going, apparently the insurance thing and the payment thing at MD Anderson is you make a decision whether or not you're going to use them going in, because they start talking about money right at the beginning,
yeah.
Which I don't mind one bit, because honestly the last 4, 5, maybe 9, 7 days, what normally happens is they set up an appointment, you go in, and quite honestly, if you don't pay them, they send you away. That was what my experience was at the imaging places, which was like, I don't know, was the place that did the CT scan, and because I have a super high deductible, I'm self-employed, I do my own thing, I always have been kind of, and I hate insurance in general, but I have health insurance, but I have a $10,000 deductible. So when I go to these places, they want payment when I get there. They wouldn't do the bone scan unless I gave them $600.
Yeah, yeah. And you're going to run through that 10,000. If that's your ceiling, you're going to run through that real quick.
I know. I'm just hoping that all these payments that I make in advance. I know my out-of-pocket expense, my understanding annually is $14,000. It's the $10,000 deductible, and it's $4,000 on the 2080 copay. So, and I'm fine with that, but what I was going to try to get at was that MD Anderson, they informed me today that I can either go in full boat with MD Anderson, pay them the balance on my $10,000 and the $4,000, which is the amount that I have to pay out of pocket, and they'll start me doing whatever it is they do. Or I can go in on a consultation for $1,000 plus $400 for some review of, I guess, review of scans or something.
CTs, yeah, right.
So
and then after that's done, then I can decide whether or not I want to stay with MD Anderson. They'll take the $1,400 and apply it towards my $10,000, but I have to pay the $14,000 before they'll do anything.
So Ken, if it were me, I mean, we can't really give medical advice on this call, but I can tell you what I would do. I would definitely, if I knew that I could have either logothetis or Korn supervise my treatment and be my main doctor, and especially if I thought that, and this is something you want to just talk to them about, if I thought that I could get some of the protocols done locally, like in Mesa, so I didn't have to drive long distances to get my chemo, I would go to MD Anderson in a heartbeat. I mean, these are two of the best genitourinary medical oncologists in the country. By the way, Steve, Paul Korn was the guy that did the paper with Andrea Hartstark about using platinum, carboplatinums early in the disease process.
Yeah, I think you're going to, just from a medical insurance standpoint, I know a fair amount about it, you're going to blow through that money one way or the other. You know, that $14,000 is gone. And you just want, after that, I don't care who you go to, whether it be a private medical oncologist in Tempe or Mesa or wherever, and or MD Anderson, or I know Cleveland Clinic is also in the Phoenix area. That's another option as well. You just want to get somebody that knows what they're doing, because you're going to spend that $14,000 regardless. I mean, that's going to be gone very quickly.
No, I understand that. I mean, my annual in my head, I always had insurance because it was, you have to have it pretty much just in case you get sick. If not, everything's gone. You know, I've worked 56 years, and all of it will be gone if I don't have insurance. So I have insurance. Thank God. This year I almost canceled it. For some reason in November I didn't cancel it. I just didn't. I was close because my insurance premium went from $400 to $600, and instead of canceling, I took it from like a $5,000 deductible to a $10,000 deductible.
Yeah, well, there's no, you can get coverage for pre-existing conditions under the ACA, so even if you cancel it, you'd still be okay. But with that high a deductible and ceiling, you're going to blow through that. I mean, you know, it's just this is a very expensive disease.
I don't want you guys to take your time on insurance because I know it's money that's going to be spent no matter what. So let's talk. We can talk about other stuff. But I do.
Ken, I have a question. Ken, I have a question. I have a question for you. You've got you're seeing doctors right now that have put you on hormonal therapy, and they said come back in 60 days or something. Did they indicate that when you came back that you would start on chemo? Did they talk to you about chemo at all?
They did not. They did not.
No.
Okay. That's interesting.
Really, when I left his office, I got the impression my life was 1 month, you know, at the moment. You know, he said right now you're going to get a shot a month for a little while, and then you're going to get a shot that's good for 6 months. And my impression was that was the treatment.
Yeah.
That's when I said, you know, how long have you been treating people like this? And he said, oh, we started doing this when I was in grad school. And I said, how? He said, 28 years ago, that was the protocol, Lupron or something like Lupron. And he said, in 28 years, you haven't done anything different? And he said, no. And I said, you know, that's when I said I got to do something else. I'm not waiting for him to give me a shot in the ass every 30 days.
Yeah, I mean, and I think I have to tell you, I think Steve was being generous in assuming that this guy might have had chemo in the back of his mind, because my impression when you told me that was that he was going to leave you on chemo for a while. But that's why I really think get yourself over to, you know, MD Anderson seems like the best option. You've got opportunities with both doctors, you know, with two excellent doctors. Ken, we can talk. You and I can talk later on. We need to move on because I want to get to some of the other guys. But
I understand.
Rich, I just wanted to say one thing. Steve talked about some of the problems he had with chemo, and I just want to touch on the fact that I've had 13 sessions, 13 months of chemo. 3 months of doxycycline that you're going on, and the balance of cabazitaxel, and I've had very minimal side effects. I mean, your life can go on. You may have some fatigue. You may have some constipation. But, I mean, there are men that really get wiped out. I'm not saying that couldn't happen, and Steve, I think, had some difficulties with it. But there are people like me that their life goes on, and it's just another treatment with some difficulties, like losing your hair. My hair has gone back, but I was totally bald after the first 3 or 4 months. But those are just minor hiccups compared to the benefit that it can be for chemo that has been showing through clinical trials now, kind of revitalized from the old days. So I wouldn't get yourself worked up about, oh, I don't know if I really want a chemo, because if that's what they suggest, take a deep breath and go for it. It could be relatively painless.
No, Ron, I wasn't meaning to imply that you should refuse chemo. I agree with you. I mean, I got through it as well, and it's not as bad as I even anticipated. But it's no fun. I mean, that's for sure. You know.
Right. I just didn't want to leave the impression that, you know, something he had to dread. You know?
Yeah.
I think that, Ken, the chemo affects every man differently. There are some men who have had 50, 60 different sessions that they just do it as a way of life because it hardly bothers them. There are other men who just can't tolerate it. You just don't know until you start. What we do know is it's very effective. And what I was going to say to you was, we hope that you'll stick with us because we've got so much experience here, and we can help you when it comes to the chemo. We can give you ideas and thoughts and some tips as to, you know, what to do, where to go, if you've got nausea, if you've got neuropathy, whatever it is. There's really a lot of experience. I mean, we've got, I don't know, 10, 15 people on the call today, but there's probably 40 or 50 men that circulate through this group. And we just have a lot of experience, and every one of us wants to make it easier for the next man coming down the road. That's why we do what we do.
Do you guys recommend going to these in person, you know, like meetings?
Well,
and I don't know. And in the beginning, I was thinking yes, but I really don't. I mean, I've been a real estate broker for a long time, and the reason I don't have any agents is because they bring life with them, and life, sometimes their life sucks life out of me.
That's right. Well, look, here's the problem with the meetings. Most people who are going to attend those meetings are not going to have the same type of disease like you have. And in a way, it's one of the reasons I wanted you to listen into the call last night. What you're going to hear in the meetings is pretty much what you heard on Peter's call yesterday.
I understand that too.
Right? And that can be really disheartening for somebody like yourself, because you say, look, these people, you know, they're not really as sick as they think they are because they got disease that can be cured. And here am I, and what am I going to do? And then you talk to the moderators and the people there, and they don't know what you're going through. They don't even know the treatments. So there aren't that many advanced cancer groups. You would need to look at us two and see if us two has any advanced cancer groups in the Phoenix area. If they,
I've already looked. They don't.
They don't. That's why we run this group, Ken, because we bring together people literally from all over the world who do have advanced cancer and can talk to you about advanced cancer and empathize with your situation. I mean, you can hear. I mean, we got guys here who have been diagnosed in comparable situations to you. And we do. Right. The one thing I do want to say to you before we finish is that I want to ask you, do you have an exercise regime?
You know, in the past, I've always been a hiker, but recently, in fact, today was my first day of yoga.
Okay.
So I know I need to deal with like the mental drain part,
right,
and try to get myself in a healthy, because I'm an emotional guy, and I just have to deal with breathing.
Right. So,
because I haven't told many people, because I can't.
Peter, go ahead.
Ken, this is Peter from yesterday, and I've corresponded with you on Inspire. Do you have a partner or some kind of a support system? So when it comes to treatment, do you have somebody who can go along with you and do the driving? You know, be there for you?
You know, I don't have.
That might be one reason to go to some support groups to see if you can connect up with someone who
I appreciate.
Can be there for you.
No, I do appreciate the comment. I said, you know, I don't have a partner, but I have lots of friends, and I've already been driving me because you guys made it clear on that Inspire network that don't go by yourself. So the last 4 visits, I took your guys' advice, and I definitely haven't been going by myself.
Okay.
Okay, good, because you're going to need some support with treatment along the way. You know, so you don't want to muscle through this by yourself. You're going to need extra sets of ears and just some compassionate souls to help you along, because sometimes you might not feel like doing anything. And that goes with exercise too. With Lupron and bicalutamide, you're going to feel the effects not right away, but within the next couple of months, it'll start kicking in too, and it'll kick your butt somewhat. And you just need to need the encouragement to keep going. And that's why Rick brought up exercise. Exercise for me saved my life. You know, you hate going to a gym or whatever, but you got to make yourself do it. And it not only affects your mental attitude, but with Lupron and bicalutamide, it helps your bones and helps you physically tremendously.
So are you recommending more than just yoga?
Yes.
Okay.
Yeah, I mean, you need the yoga is great. It'll keep you limber. It'll help you with stress relief. But you need aerobic and you need some weight resistance exercise because of the hormone therapy. And
okay.
in addition, once you're on chemo, believe it or not, the exercise alleviates a lot of the side effects of chemo. Again, there have been studies, we know this. It seems antithetical, but it actually works, even if you just go out for a 15-minute walk.
Yeah. No, I understand. I've been doing walks because it helps me clear my head.
Okay.
Yeah.
So,
Can I say something, Rick? Ken, this is Jake. I want to make three comments actually. Everything that everyone has said to you is spot on, is very good advice. One thing I would strongly recommend is that you take a recorder with you when you go to the doctor, so you can go back and listen to what he says. I don't know about you, but I forget half of what I hear, so I take a recorder, and that always helps me. And the other thing I was going to recommend is every other Thursday, there's a meeting called Inner Conversations that is moderated. It's for people with cancer in varying stages. It's not technical. You know, don't ask any technical questions because we don't know. But it's basically a place to kind of vent your feelings. You know, how does this affect me? How am I feeling? You know, how did you deal with it? It's kind of like a place where men can just talk to other men. There's no women, and just kind of let loose. It's therapeutic and it's very helpful, and I would strongly recommend you join us. It's every second Thursday at 8 o'clock, same place, same number. Next meeting is Thursday Thursday the 13th.
So is it on this place, or what are you saying? It's the same place, same number?
Yeah, same place, same number you called in tonight, or you're on the computer, right?
Oh, I'm on a tablet.
Okay. Yeah, same thing, same everything. Everything's the same access code. Everything's the same. Just 8 o'clock Eastern time. I guess that's what, 7 o'clock your time.
No, right now it's 5 o'clock. So what time?
You're 2 hours.
right.
So it's
So it would be it's 8 o'clock Eastern time. I guess it would be 6 o'clock your time.
right.
So,
I'll give it a thought and listen. Yes.
Jake,
Pardon me?
Jake, I just put Ken's email address in the chat window for you. I sent it to Steve as well, but that was a mistake, Steve. I didn't mean to send it to you. And so maybe you can just add Ken to the distribution for the call.
Okay. It starts out REATA.
That's it.
Ken.
That's it.
Okay, we'll
So
do.
just add him to the distribution. Ken, our next call is, it'll be next Monday. We meet every week. And just keep coming in and talk. We've got a lot more to talk to you about. We haven't even touched on diet yet, but we will, because there's a lot of diet issues. And I do think that diet is, again, it's kind of like the metformin and the statins. It ain't going to cure you, but it's not going to hurt you, and it may well help you. So we'll talk to you a little bit about that. But I am going to move on because I want to get to Ron, Paul, Eric, and Peter. So we'll talk to you again very soon.
All right. Thank you for your time.
Pleasure. Hang in, listen to us, and you know where I am. You can reach out to me, and you know, if you want to talk to any of the other guys one-on-one, I'm happy to connect you to them.
Okay. Thank you very much.
Pleasure. Ron, you're up.
Well, I just wanted to bring you up to date and some of the other guys. As I've said before, I finished my 12th session of cabazitaxel chemo in December and was planning on continuing into January, and I came down with the radiation cystitis to my bladder, which we've talked about.
Right.
That wiped me out. I lost 20 pounds, went on morphine, and was in pretty bad shape. Actually, I had 2 units of blood transfusion during that period of time. So I'm gradually getting back from that. I met with my oncologist early this month, and we decided to move ahead with chemo because he said change of attitude. Instead of saying let's drive the PSA down from wherever you are, let's see if this slows down the acceleration of the chemo. And he says, you know, slowing down the acceleration is as good. It's not as good as pushing it back, but that's not a bad thing. I ended December, well, actually, the low point that I got on my PSA was 149 from 800 when I started a year ago. 800 PSA to 149. It started creeping back up in November and December, so I ended December at 203. When I was off the chemo for a month and a half, I took my labs on February the 10th, and it shocked both myself and my oncologist. My PSA was 851. He was concerned, not so much because it was a month and a half. Yeah, you could see the PSA increasing, but that seemed to be significant. He wanted me to retake my PSA because he says sometimes, you know, the labs do screw up a bit. I took more lab work prior to my chemo 12 days later, and my PSA was 672. So I guess there was some, without doing anything, so I guess there was some feeling that that maybe that was a bad lab at the 800 level. 672 is still bad, but not as bad as 800. Anywho, I had my 13th chemo last Thursday. Amazingly, I haven't felt I haven't had the side effects or the fatigue and stuff that I experienced prior, and I'm in my second week, obviously. I did mention to my oncologist the last time, told him that I wanted to take some time and discuss this geno testing. I wanted to get some more advice from you, Richard, before I saw him in about 3 or 4 weeks with some information on that. But anyway, I just wanted to bring you guys up to date. My radiation cystitis has gone away.
Good.
It's a great thing. It's gone all away. I'm trying to, you know, I'll tell you one thing. When we were in our 30s and 40s, trying to lose weight was a bitch, and we put it on, you know, in one meal. I've managed to put on 8 pounds in about 3 weeks. So, and I'm eating as much as I can eat. So that's all good.
Okay.
So Ron, you're back on, is it Jeptana or what are you on? What's the chemo?
Oh, I'm sorry, cabazitaxel.
Jeptana, yeah.
Yeah, Jeptana, I'm sorry, yeah.
Yeah. And your last PSA was 672, is that right?
Yeah, correct.
And how about your outcross? Where's that been at?
47.
Okay, so it hasn't gone up a whole heck of a lot, your alpha.
No, my alpha has remained in the 40s for the last year. My last scan, bone scan, was hang on one second. Was about 3 months ago, and everything was. My last bone scan was was November 16th, and it was stable, no soft tissue activity. So
that was a CT or a bone scan?
Well, that was a bone scan. I had a CT scan in August, and that was no soft tissue.
So no liver metastases?
Pardon me?
I wonder where the PSA is coming from, you know? I mean, that's remarkable that
that's an interesting thing. When I don't seem to have any activity, I have no bone pain. You know, something's chugging along. I have no prostate, so I don't have any major tumors. All of my metastases, about 22 of them, are minor.
Yeah.
You know, it's the same old story that this disease is so diverse. We got people like you that make loads and loads of PSA, and you don't seem to know where it comes from. And then we've got people like Eric and Jim who make no PSA, and they
and you know the interesting
small cell disease.
The interesting thing is, I was on hormonal therapy, just strictly Lupron and Casodex, for 4.5 years. And my PSA at that particular time, during that time, was below 10. You know, I mean, so I really reacted at that particular time to hormonal therapy. I failed both Xtandi and Zytiga. I probably have the mutated gene, but I failed both of them within 4 or 5 months. And neither of them drove down my PSA any, you know, in the 4 or 5 months.
How did what was the reaction from the med-onc when you asked him to consider genome sequencing? Was it just, well, we'll talk about it next time, or was there?
Yes.
Good. Okay.
Yes, it was. We'll talk about it next time.
Okay. So
I want to get back and get the names of that gal up in Northern California that you know, and get a little bit more information about this. I don't know, Steve. You know, does Kaiser work with Foundation One, or do you have any knowledge of that?
Well, I do, and I did do the, the liquid biopsy just on a blood sample because I didn't have any tissue, and Kaiser rejected the payment, and so Kaiser's still at a point. You're in Southern Cal, Kaiser, I know, so it may be slightly different. But Andrea and up in Northern Cal here is not a big proponent of it. But
she's not.
Well, I mean, she's a proponent of it, but Kaiser's not going to pay for it. That being said, I mean, it's not that expensive. And interestingly, when I talked to Foundation One, in Cambridge, they asked for an income statement and all of this. And, because I don't have any income, I live off of basically all the money that I've saved over the years and don't have any particularly high income. They said, well, you won't have to pay anything. You're basically, we wouldn't bill you. And then I talked to one of the people there, and I said, well, how high an income do you have to have? He said, well, we're not billing anyone really at this point because we're getting money from the drug companies. So even though Kaiser, and I didn't appeal it, and Kaiser didn't care, and neither did Foundation One. So it's kind of up in the air. You can kind of, if you do it on a tissue sample, obviously the more recent the tissue sample, the better. But you probably don't have a tissue sample for quite some time.
No, I don't. I was going to ask you now, did you do your liquid biopsy at Kaiser?
Well, it's just a blood test. I mean, you just go in and Foundation Medicine sends you a kit, and my oncologist did agree to order it, but it was denied. The actual cost of it was denied. The cost was about, I got the bill, it was about $5,000, give or take, I forget. And it was denied by Kaiser, and they said, well, you can appeal this. Kaiser said that, meaning that they thought it was coming out of pocket for me, and I said, I don't care, not coming out of pocket for me. So nobody seemed to bother about that, and that's been quite a few months now. So I would talk to Foundation Medicine first about the cost. Make sure that you're not going to get billed the $5,000 because Kaiser will deny the cost. But the test itself is a very simple test. The problem is when you do the genomic sequencing on blood, so-called liquid biopsy, and this is not circulating tumor cells. This is actually circulating DNA. It's only a panel of about 60 different mutations, whereas if you go to one of the dream teams, UCSF or down at UCLA or one of the other places that are doing this, I mean, you're talking 500 different mutations or more.
Steve,
yeah.
Steve, hold on. You're talking apples and oranges. So the dream team does a solid tumor biopsy.
That's what I'm talking about, on a solid tumor. So the question is, you don't have a prostate.
And Foundation Medicine also does a solid tumor biopsy. And if they did a solid tumor biopsy, it would be a comparable number of genes that they compare it to.
Not my understanding, Rick. I understand UCSF's panel is much larger, but be that as it may, it's a larger panel on tissue.
It's not much larger. It's about, the panel that Foundation Medicine has is about 360, and the panel that the Dream Team uses is in the 400s. The big difference is that there's no RNA test if you go down to Foundation Medicine. But when I asked Larry Fong whether there's a big difference between the Dream Team and the Foundation Medicine, he said essentially it makes really no difference, that they're very, very comparable. Because we had a guy and we were trying to decide where it should be sent. This wasn't Trevor, this was before Trevor.
So for you, Ron, though, since you don't have a prostate, you're talking about a bone biopsy if you're going to do tissue. So for you, I mean, it might be a good candidate for just doing the blood, you know. I did it. It proved to be very unhelpful. They found a P10 and a TP53 mutations, both of which don't have any existing chemotherapeutics that are effective in other cancers. So it proved to be not very effective in terms of managing treatment or moderating treatment. And my own oncologist was sort of saying, well, see, told you so kind of thing. But, you know, I don't know. I mean, they may find something.
Well, you know,
Richard, the question I had, and your knowledge and experience on this, is let's say they find some pharmaceuticals or drugs out there. I mean, is this something, let's say they came back and said, here, Ron, well, could these be drugs that I could get through Kaiser? I mean,
okay, so let me just step back one, because I've actually asked Steve that very same question. First of all, I think that if you're going to do this, and I've said this to Steve, you really need to do it with a solid tumor biopsy. I think to say that, well, see, I told you so, when you do a blood biopsy, is probably not giving the test a fair chance, and that if you can get a solid tumor biopsy, you're much better off. Now, again, whether you could do that at Kaiser or not, I'm not sure. I know Steve had issues because technically they don't do it that often, and so it was suggested that if he wanted a solid tumor biopsy, that he might be better off getting it from UCSF. I don't know. If you have a solid tumor in soft tissue, it's pretty easy to do it. If you don't have a solid tumor in soft tissue, it's not as easy. It's not a difficult or really painful process. But and I say that I haven't been through it, but I know many guys who have, probably 4 or 5, not many, but 4 or 5 who have, and they've all been relatively comfortable with the process. Having said that, it may be difficult for you to get it done at Kaiser. I don't know.
Rick, just to, your CT scans have to show an active lesion that's accessible to biopsy.
Correct.
If it's old sclerotic lesions, in other words, there's nothing active and it's not in a rib or somewhere they can eat, they won't biopsy your spine. So if they can't get it in a bone that's easily accessible, they can't do it. So I was going to go to UCSF. I talked to Larry Fong as well. And then I had the UCSF interventional radiologist review my CT scans, and they said, there's just not enough active disease there that we can biopsy it.
Right.
So that's why I chose to go to the liquid biopsy. And I think you might be in that same scenario. So it's not a Kaiser UCLA thing. It's more of a, you got to have active disease in the right spot.
Right. Do you have metastases in your hips or your pelvis or your femur?
yes, I have it in my back, around in my spine.
Right.
I do have some on my pelvis.
Okay, so if you have your pelvis, your hips,
one on my head.
if you have it, your hips, your femur, a lot of times your pelvis, those can be accessible. If they're in the spine, it's much, much harder. The ribs are tough because they're small, they're more fragile. but again, as Steve says, they'd have to take a look. Now, I spoke to my guys at Foundation Medicine. You know that one of them's on our advisory board. And he said, when you're ready, they stand by waiting to help you with Kaiser, with respect to Kaiser. The other thing is that Steve and I are trying to work with Kaiser to see if we can create a working relationship between Kaiser, Northern California, and Foundation Medicine. I mean, it may not help you initially, but if once, and it may not help you just from a time standpoint because it's going to take time. But we recognize that genome sequencing should be available to Kaiser patients. Kaiser has a long-term plan. Northern California may have a long-term plan, but we want to accelerate that. And so Steve, God bless him, is trying to help us make the right inroads, and then we were trying to get Kaiser talking to Foundation Medicine. But in the meantime, Foundation Medicine people are willing to help any Kaiser patients that I bring to them.
Or any insurance company. It sounds like Foundation is making a boatload of money from the pharmaceuticals, and they're not too worried. They want to get as many patients screened as possible, in particular tissue. And so my impression in talking to them was that we're not as worried about the money as enlisting you as a patient. And like I said, Kaiser denied it immediately, and I didn't choose to appeal it. If I'd gone to an appeal, they may have said, fine, we'll pay for it. I don't know. It was not that much money. So I didn't follow through on the process of appeal because it wasn't being billed to me anyway. I would certainly look into it, you know, in terms of the insurance.
Richard, the second part of my question was, after you've done this, what about the pharmaceuticals and the drugs that they may?
Right.
Yeah.
Well, I'm gonna defer that one to Steve.
Yeah, it's up to you. Any drug that is FDA approved for any disease can be used for a non-FDA approved usage if the doctor feels there's reason to use it. And in Kaiser in particular, you're actually better off than in the fee-for-service world where the insurance company may not pay for it. So if there is a drug that's used in, let's say, Lynch syndrome or, you know, in colon cancer, and you find you have a mutation that is that there is an effective drug for it, olaparib is a great example in the BRCA world, you know, the PARP inhibitor stuff. So you can, the short answer is yes, your oncologist can order it as long as it's FDA approved, even for not for this cancer. If there's something that they can say when they go to pharmacy and therapeutics like, yeah, but on genomic testing we found that he had this mutation, and nobody's going to give that person a hard time. So Kaiser is actually, in that sense, a little better than the Blues or, you know, or another, you know, United Health or some of the other big insurers.
Thanks, Steve.
Okay, Ron, if you've got more questions, just reach out to me. I'm going to move on. Paul, are you? Yes, you are still with us. Just tell the guys about your house moving, as it were, in the last few days and what's going on.
Oh, I've moved from a rehabilitation hospital to a nursing home, so from one room to another. Where I am now, I've got a mobility scooter which I'm learning how to drive. That may provide the opportunity for getting out and about a bit more and getting engaged in some quality of life activities. That's pretty much, and at the moment I'm sitting out in the sunshine. It's about 90 degrees here as we head into fall. So the scooter's giving me some opportunities. I've just got to learn to drive it.
Is it difficult to drive it?
There are a lot of scratches and chunks of paint out of some of the doorways around the nursing home that I don't think were there 2 days ago.
I see. So, I mean, does this mean that if you were to have a head-to-head race with Mr. Marshall right now that we would have to give you a handicap?
Well, I probably would, because I'd put it into reverse instead of forwards, or turn the joystick the wrong way, or go into a spin. It's quite delicate, and if you are a bit rough with it, it does unusual things.
I see. I see. And I hear this is a test one and that you're in the market to buy your own.
Possibly as something to get me around when I've moved into this new nursing home. I've leased one for a fortnight or so whilst I look at other models and so on. One of the problems is that with my leg muscles, I can't get into a normal car, transfer from a wheelchair into a normal car or taxi, so that I'm having to deal with wheelchair accessible taxis. So not quite as mobile as I would have liked to be.
So you're looking for a drive-in and drive-out version that you can drive right into the taxi and drive right out of the taxi?
That's correct, yes.
Okay. All right.
Jim's is a lightweight model that he uses for putting in and out of car boots and hopping on aeroplanes.
Right. And how are you feeling? How are your spirits?
Oh, okay, good at the moment, thanks.
Good.
I'm halfway between treatments at the moment, so won't know. The next one's the end of March, so not much else to report till then.
Okay. Well, as always, it's great to hear your voice, and it's good to hear that you're making some life arrangements that are going to improve your quality of life and make it easy for you. Anybody else want to talk to Paul? All right. Well, we'll hopefully we'll talk to you next Monday. Eric, give us an update.
Well, I got a new PSA, and it's went halfway back down to it's 8.8 now, so that's encouraging. But my out of breath problem continues to get worse, and it's now pretty much affecting anything physical I do. So cardiologist, pulmonologist, everybody just says, well, all your conditions are fine. I don't know. So I guess until something major happens, I won't be able to get anything done. But I'm continuing to see the cardiologist. I haven't seen a pulmonologist in a while. But that's about all I can say about my condition at this point.
So I mean,
starting on my eighth month of the GS 5829 experimental drug.
Right. I thought I saw some discussion last week, and I thought you and I may have talked about it, about the fact that the hormone therapy could be causative in the shortness of breath.
Right. But I still, I guess I could stop doing the hormone therapy, but it's something it's hard to live with.
Right.
I mean, if I just reach my arms up and pick up something heavy off a top shelf, I'm out of breath.
Wow. It's a little surprised, Eric, that they don't, just throwing their hands up and saying all the studies are normal when it's that debilitating is surprising. It seems like they should be able to figure something like that out. If it is a medication side effect, obviously the only way to do that is to challenge you by stopping the medication, see if it gets better. I don't know. It seems like it's gotten worse from what you're describing, because, a few months ago you say you go up a flight of stairs, you get short of breath.
Yeah, I was at UCSF yesterday getting my next month of meds, and I was in the waiting room, and I stood up to go in to get my vitals taken, and my blood pressure was 77/60.
Really? Wow.
They weren't going to let me go home. But then I had to. They were supposed to give me hydrate me, and they didn't seem to be able to do it for 3.5 hours as I was waiting there. So I finally just said, "Forget it, I'm going home." They said, "No, you can." I said, "Take the blood pressure. I'm sure it's boiling now." After 3.5 hours of waiting for you.
What was it? So don't leave us hanging. What was the blood pressure?
125/90.
So the answer is we have to get you pissed off.
That's it.
Oh boy. You know, I don't know. Any thoughts, Steve? Any thoughts for Eric to pursue?
No, I mean, I think you've done every, you know, I mean, you've seen a cardiologist, seen a pulmonologist. I mean, obviously it's nothing common, and, you know, and then if you can't figure something out, it's usually medication side effect. And the only way to find that out is to challenge you by taking you off things, and that may not be in your best interest. But, I mean, if you raise your hands over your head and you're short of breath, man, that's significant, man. That's like pretty debilitating. You know, your docs know that it's that bad?
Yeah. Oh yeah.
I don't know.
Yeah, they gave me the beta blocker to bring my heart rate down. My heart rate, when I started taking Zometa, my heart rate went up, and my resting heart rate was 110. It's down to 85, taking 100 milligrams of toprol every day. But that doesn't seem to make a difference. When I get out of breath, my heart is racing. I have a pulse oximeter, and it says, you know, that my oxygen is 98 or 99, so that's not the problem.
Yeah, it's probably not pulmonary then. I don't know, man. I don't know. I mean, it's a tough problem. I don't know what to say.
Eric, I've been off of Lupron and Casodex now for 10 weeks. I'm on, you know, I'm going to see how long I can stay off, but I've noticed a difference, particularly in the last 2 weeks. I can do a lot more. I don't get out of breath. I don't feel like I'm going to collapse at all. So I think my guess is that the ADT has a lot to do with it somehow, but I can't prove that. But I know I feel a lot better.
Yeah.
Well, I'm skipping the Zometa. They first put me on 3 months instead of 1 month, and now I'm due for the Zometa now, and I'm not going to take it. See if that helps with the heart rate and with anything else.
One idea, it might just be worth bouncing off of Agarwal. I don't know whether it would work in your trial, would be to go to high-dose bicalutamide, high-dose Casodex, and drop the Lupron.
Okay, I can ask them.
And see if it helps your breath. I mean, for the purpose of helping your breath. And
see, the problem, Rick, is when you say dropping the Lupron, that's a 3 to 6 month investment.
Well, that's right. Yeah.
Oh my God, you know, it doesn't go away. So once you, it's 6 months before it's really gone. Once you get an injection.
That's right. It's not immediate, but I'm going to see Agarwal tomorrow because there's a presentation on small cell and neuroendocrine disease. And they're going to focus on prostate cancer as well as some other cancers. But one of the main topics is going to be prostate cancer. So it's a presentation from 12 to 2 tomorrow that I'm going to attend at UCSF. And he's one of the speakers along with Emily Bergstrom from the colorectal group. So, you know, I don't know that they'll talk to me anyway, but I could try if I can. I could see if I can push him a little bit on thoughts that he has about this. I mean, you know, you're not the only person. But I think you probably have the worst situation. Is there anyone else on the call struggling with these breath problems?
No, Peter was, right?
Right, yeah, but I've noticed a big difference in the last 2 weeks. And so my last Lupron shot was 5.5 months ago. So that was a 3-month shot.
Peter, have you tested your testosterone?
I'm going to do that next Monday at Marina Del Rey at Turner's office.
Okay. Don't know, but you know, it's just a thought. But Steve's exactly right. We don't know how long it takes your testosterone to come back. I mean, some guys comes back 3 to 4 months. Some guys it can take 2-3 years. So we just don't know. And you know, it's a high risk strategy. And the bicalutamide is probably not as effective as the Lupron. But you know, we're sort of clutching at straws, and like Steve says, if it's a medicine side effect, at least if we knew which medicine it was, it would be a start.
Yeah, it's pretty much, you know, as long as the cancer is held in check, they don't really want to do anything.
Well, and how do you feel about that? How do you feel about that trade-off of dealing with the shortness of breath as long as the cancer is held in check?
Well, if it gets much worse, I probably will change my opinion. But right now, I still want to stay the course. So.
I want to say one thing that I've personally noticed is that you seem, you come across, and when we've seen each other recently in person, I feel that you're much more positive than you were, say, 6 months ago, and you're in a better frame of mind. And I'm really personally happy to see that.
It's up and down, but it's more up than down these days.
Right. Hang in. We may.
Thanks.
I don't know if you. We can talk about this offline, but if you're interested, but John Teisberg is in town, arriving tomorrow, and I will be seeing him. So let us know if you want to be entertained. Okay.
Oh, that'd be fun.
Why don't you take him for a row, Rick? Why don't you take him for a row in that Aero 24?
Yeah, that'd be perfect. What do you think, Jake? Should we take him out in a boat? What do you think? Maybe he could. You know, it would be one of his funeral ships.
Yeah, you never know.
Steve, do you know about John Teisberg's funeral ships?
Yeah, I do.
No, sorry, Steve. Do you know about them?
No,
Well, he has a sideline business. I'll send you the URL. But he makes model Viking funeral ships. And what you do is you put the remains after cremation in the bottom of the ship, and then you push this thing off the side, and it sails out. And then at some point, wherever it's sailing, it ignites, burns up, and goes to the bottom of the water.
It's a Viking funeral. That's good.
Exactly right.
Yeah. Tell him we all got together and decided he needed a one-way trip on the boat.
And for those of you who don't know who we're talking about, it is our venerable founder of the Reluctant Brotherhood, who also at this point happens to be somewhat nominally the chairman of Answer Cancer Foundation, who is a hoot. And if you haven't seen yet his animation of how the prostate works, you'll find the reference on our website or on YouTube. I strongly recommend you look at it because A, it's educational, and B, it's a lot of fun to watch, and it's accurate. So
it's brilliant. Yeah, it really is.
It is brilliant. It is brilliant. He's a graphic illustrator by trade, so and a lot of fun. Ken, if you're still with us, Ken, if you join the Inner Conversations group, you'll have the privilege of experiencing his humor.
I'm still here, but I'm off to meet a client. So
Okay.
Ken, before you go, I want to make a correction. I said the 13th of March. It's the next Inter-Conversations is the 9th of March.
Oh.
It's a Thursday, 9 March.
Okay, but we'll send you. You'll get a note. You'll get a note.
I appreciate the conversation, though.
Okay. All
Well,
right.
we look forward to seeing you.
Okay. So let me see, Peter. Would you like to fill us in, or talk about whatever's on your mind?
Sure, unless somebody else has something that they want to talk about personally. Mine isn't related specifically to my situation.
Now, why don't you go ahead and then let's see what time we have at the end. I think we've gotten everybody. We don't have anybody new on, so take the time.
Okay, well, I'm headed next week to Southern California and Northern California to I've been invited to to participate as an e-patient for the Coalition for Compassionate Care California, which is an annual conference dealing mostly with hospice, which I don't really deal with, but I wrote up a proposal to go based on my participation in this and on the Inspire website and other things, just helping guys and getting help by comments and influence by other guys. And they liked my proposal and they said, come on out, I'm sure you can add something. But it got me thinking about end-of-life issues. Particularly, I don't know if anybody's followed on Inspire or Health Unlocked the saga of Eric Winters from Chicago. Actually, his first name was Charles, I think. But he went into hospice just before the end of the year, before the holidays, and up until then, he kept a very active kind of blog thing going with Inspire and with Health Unlocked. A lot of people followed him, and he kind of updated everybody on his fight and everything. But then he just vanished. He went into hospice, and I think he made one comment or something like that after that, and then nobody heard anything else. And it made me think a little bit about how we kind of prepare for the end. That do we somehow make some kind of arrangement that people can follow us. So Rick brought this out with a guy I work with here, to see if I could get him to at least put me on his health directive or something, so I could access his medical records from his doctor. Really help him out, because it concerns me when people just vanish. Maybe it's none of our business. I tried calling hospices in Chicago, but of course they can't talk to you. They can't say anything to you on the phone or any other way. So you can't get information about anybody. And I'm not. It's not out of curiosity. It's just out of caring about each other, caring about our brothers. So I just wanted to bring that up because it made me think about that. It seems to be an abyss to some people, particularly if they live alone or they don't have family around or whatever. It shouldn't happen to any of us. We would just vanish from any connection with those who care about us and support us. But that's all I want to say.
Thoughts? Well, would somebody like to add or subtract or supplement or complement?
Well said, Peter. I kind of agree with you. I've been following Eric also. Tonight I'm sitting here wondering about Mike Tamales. I know you keep in touch with him, and I'm sitting here wondering how's he doing. So when you don't hear from somebody, you wonder. But Frank Kelly is another one. Frank's usually on this call. Where is he tonight? I don't know. I don't know what else to say. It's just that, we come to care about these people. It really is a brotherhood, and you kind of care and worry about them.
Well, you know, one thing that you can do is
Hello.
use.
Ann Anderson going to Mary Lyons' home on Amber Sun. Lyons. Lyons.
I'll just I'm just going to mute and.
And I'm sorry, you said your last name is?
Anderson.
Where are we? I was looking for him here. Jake, could you find, I think he's on the phone as well now. Could you mute him?
Who can?
He just disappeared. He's gone.
Okay.
Yeah, he just left, yeah.
Okay. I was going to talk a little bit about Healing Bridge, because it's a very good site that can be established by a friend or a relative, and they can post on there. Now, if you have no friends, I mean, if it's a situation like with Winter and you know, maybe you're totally alone and on your own, it's difficult. But if you have a relative, if you have a friend, then they can post on there and you follow them on there. It's a lot more general than, say, posting on the Inspire site where only your Inspire people are going to see you. I mean, we used it extensively for Jerry, God rest his soul. We used it a little bit less with Dom. I didn't do it. My sister did it for my mother. But it is a very, very good site. Does anybody have experience with it other than myself?
I'm not sure if it was Healing Bridge, but there was a similar one for my brother. His wife set up, and she would kind of update everybody periodically. It went out to everybody that was subscribed. The updates go out to them automatically. It was very helpful. It might very well have been Healing Bridge. If not, it was something similar.
I may have the name wrong. It's something Bridge. I'm having a brain fart. But yeah, but you know what I'm talking about. And I'm just looking to see if I can find the website. But yeah, I mean, and did you find that helpful? Did you find that it was an easier and a better way for you to stay on top of what was going on, Jake?
Excuse me. Towards the end, yes. You know, I tried to keep in touch with him over the phone for as long as he could talk. I'd call him every couple of days. But towards the end, he wasn't communicative. So 2 weeks or so, I had to depend on his wife pretty much to update. So yes, it was very helpful.
Caring Bridge. I'm sorry, it's called Caring Bridge.
Yeah,
Healing Bridge. Caring.
That's the one.
Yeah.
That's the one. Yep.
And there's another one that competes with it, but Caring Bridge is a great site. Have you had experience with it, Peter, or not?
No, I've heard about it, but I've never had experience with it.
Okay. You know, it is an issue. It is an issue when, I mean, I find this on a regular basis that, you know, there are guys that attend and then they just disappear, and then suddenly I think to myself, oh, they've gone, and I try to track them down. I think of the guy that was some of you may remember him, the boxer who lived out in Minnesota, Steve. You know, we knew he was pretty sick. He was relatively young. He got sicker and sicker, and we just didn't hear from him. And then, you know, after a few months, I started looking, and sadly, I found his obituary. And you know, and another one is Walt Scheel, that some of you know. Some of you know that name. Because he was very active, and people said, well, you know, what happened to Walt Scheel? Walt Scheel wasn't on our call that much, but he was very active on Inspire. I don't know, you know, not really sure how to what to say, but Peter raises a really good point. Peter, you know, it would be interesting to come back to us after your conference and see what people say about how do you track people and what can you do. Now, you may find that most of the people there are not going to have the same experience we have, because we work in virtual communities where people are from all over the world, whereas most people that you're going to talk to are going to be in a geographically confined community, so it's going to be much easier for them to know where people are. But we do have an issue.
Yeah, I agree, and I'll for sure we'll report back in. I mean, that's part of the part of my homework is in terms of getting this scholarship. I've got to report wherever I can what I experience. So I'll let you know. But I agree. I think we bring a very unique perspective into this, not only from the standpoint that we work a lot primarily with men, although that might expand, but we do that primarily with men, giving men voices, and giving us a place to speak up and open up, but also that we do work internationally and have connections with people from all over. So I look forward to it, and I'll let you know how it goes.
Okay. All right, guys. Anything else before we wrap up? Anybody have anything they want to raise before we wrap up? If you didn't hear Sam Denmead last week, it's worthwhile. Yes.
Excuse me. I was just going to say the other Caring Bridge was one. The one that my brother was dealing with was mylifeline.org.
Okay. Okay.
And it's just, it depends on someone else to do the updating, but you know, if as long as somebody's willing to do that, hopefully a family member or a close friend, then it's very helpful.
Okay.
Sorry to interrupt you.
No problem. So if you didn't hear Sam speak, we've got a page dedicated to the presentation on the website, and a link to the presentation on there. And if you want to see the slides, you can download the slides. But it was interesting, with some caveats, and you know, Steve and I have talked about it, and Steve makes a very good point that Sam is a very good promoter, but he has to be, because just like with the study that Dominic, God rest his soul, was involved with the guy with the doc at Duke, Dan, I forget his last name. You know, they're using drugs that are not proprietary, and so it's very hard to get funding for treatments that may have a significant effect, but are not unique drugs, because there's no money in it.
Exactly. The thing is, nobody will ever know if metformin is effective or not, because metformin is dirt cheap and nobody wants to study it.
Right.
There's no profit, you know.
That's right.
Same with testosterone.
The same with testosterone, and the same with you know, the copper study, the one for Dad that Dom always used to talk about, that uses what's it called, Steve? The anti-alcohol drug.
Antabuse.
Antabuse, yeah.
Disulfiram.
Yeah, disulfiram and copper. You know, and at some point pretty soon we're going to see some results from Duke, and hopefully they'll be good. But it took him a year with a lot of effort from a lot of guys to raise enough money just to start doing a small trial.
No, I mean, just my editorial comment on that is all the best researchers ought to be working not for drug companies, but for the NIH. And that's just not the case right now, because that way they're on a salary and there's no profit motive, and they can study all these drugs in a reasonable way. But when you have all the best researchers working for the big drug companies and they're advertising them on TV, it's just a hell of a way to run a ship, man, I'll tell you.
Okay. All right. Well, another 2 hours, and hopefully a lot of good information. Hopefully everybody's taken something out of this, and all being well, we'll speak again on Monday night. And thanks to all of you for attending, and thanks for being so supportive to Ken. I have the greatest difficulty personally when I speak to men who are young and who get diagnosed with metastasized disease. When I say young, I mean, and I don't mean this with any disrespect, Steve, but when these guys like Trevor or Ken Anderson come on the line and they have just, you know, metastasized disease in their early 50s or mid 50s.
No, I hear you. I hear you. I mean, I feel fortunate to live 68 years. You know, I mean, you hear these things, people in their 40s and 50s. It's just a shame. You know, it's just a shame.
Yeah. But you know, we can give him the hope and the perspective that he's going to be around for a while.
Yeah, I think at a stage of kind of confusion, and his doc is not really helping him by, you know, by just saying come back in 60 days and we'll check your PSA. That didn't sound very supportive of him. So, you know, I don't know. We'll see. We'll see how that all goes.
All right, guys.
It sounded to me like he did not get good coverage at all from his doctors. You know, PSAs of 500 and 1,000, and they were just saying, "Oh, don't worry about it."
That's fucked up, man. That is fucked up.
Yeah. Thank you for. That's exactly my thought.
Jake, that's medical terminology, Jake.
I know, it's over my head. I had to look that one up.
So Ken was reaching out on Inspire last week. That's where I first met him, and he was asking. I mean, he was just doing initial research, asking where to get treated, what to do, and he dropped names, and I kind of went out on a limb a little bit because I don't know whether to criticize or take a stand. I mean, he mentioned Cancer Centers of America, and I wrote back and said, no, you don't want Cancer Center of America. It might work for some people, but in your situation, you don't want to go there because you're not going to get.
Heard bad things about them.
You know, their advertising budget is higher than anything else. You know, that's a bad thing.
Right. Exactly.
So sometimes I feel like going out on a limb like that, and I'm not trying to be critical of Cancer Centers of America, but you kind of know in your gut that that's not where they need to go. So he was also asking about Loma Linda, and I kind of said, well, you know, I don't know anyone that goes to Loma Linda. You know, some people go for proton beam therapy, but that's about it.
Right.
You know, I guess on some level I'm giving medical advice, but I'm taking a risk. But I don't know. I mean, we've got to somehow.
Peter, I don't think you're giving medical advice when you tell somebody that you got to go to an oncologist that knows what he's talking about. I mean, that's not medical advice. You know, that's common sense.
Right.
Yeah, I think that's what, as navigators, we should be doing. We should be herding people towards the right type of medical treatment and the right things to discuss with their doctors. You know, I agree with Steve, and I think that's you're doing exactly the right thing, Peter, and exactly the right thing. Ken found me through the website. I suspect he must have found the website on Inspire, or somebody must have mentioned it to him, and he wrote.
Yeah. I brought it up and connected him up right away. I think I was the first to respond to him. As soon as I realized he had pretty serious disease, I said, you got to get good help.
Well, hopefully, look, with Logothetis or Paul Korn, he's going to have really, really good guys. I don't know much about Logothetis' bedside manner. I do know that Paul Korn is just terrific with the patients. I've had two guys go to him, and they both thought he was just super. Go ahead.
We have a new caller. You might want to. He just logged on. You might give him the schedule.
Oh.
Caller 7.
Somebody just call into the call.
Yeah.
Yeah, probably. You put 5 o'clock Eastern or something.
Who is this?
Right. See you, gentlemen. Take care.
Okay, take
care. Steve.
Guys, we'll just talk a little bit to whoever it is. Who is it that just logged on? Do you want to let us know? Hello?
It might be me. I'm Rich Catapano.
Oh, Mr. Catapano, how are you? Yes, we're about to close.
I know. Our information was 8 o'clock.
The 8 o'clock is, this call is a 6 o'clock call. The Tuesday is 6 o'clock, and Monday is 8 o'clock, Tuesday is 6 o'clock.
Okay. Now I have to have my eye checked.
But it shouldn't be a total loss, because I should be able to post it on the website within about 2 hours. You can listen to the call on the website.
Oh, okay. Very good.
Okay? I should have it up there within about 2 hours on recordings and calls on ancan.org. So you'll be able to listen to it then. Yeah, our Monday calls are at 8 p.m. Eastern, and our Tuesday calls are on 2nd and 4th are on at 6 o'clock Eastern. Because the Eastern guys told us 8 o'clock was too late and they needed an earlier time. Okay?
Okay, thank you.
All right, it was a good call. You'll hear it. Okay?
Yeah, looking forward to it.
Okay. All right.
Have a good night.
Take care.
Good night. Good night, Rick. Good night, Peter. Good night to whoever else is on the call.
Good night,
thank you, Rick.
everybody. Speak to you soon. Bye.
Bye-bye.
It's not letting me hang up here.